Uh, Thank you so much, Dr. Ajay Paul, for having me here. And well, Dr. Ajay, he wanted me to cover up the IOL choices, but I think that almost the entire thing has been covered up already. But anyway, I will try to just go through all the choices that are available as of now. So we all know this has already been discussed, that it's the displacement or the malposition. It may be partial, it may be total, and the management, actually it depends upon what type of disorder is it, whether it's a progressive or a non-progressive zonulopathy. You have various degrees of subluxations. You might have a mild, moderate, or a severe kind of thing. So your modality of treatment actually depends upon the clinical scenario which is present there. You have wide choices. You might have a one-piece or a three-piece foldable IOL to put inside. Again, that's a personal choice. Many of the surgeons, they would like to go ahead with a three-piece IOL. That's my personal choice in all these cases. But there are surgeons who are also using one-piece foldable intraocular lenses. You have various other beautiful capsular bag supporting devices which can be used in association with the intraocular lenses and the CTR. So what I'll try to just showcase and run through these videos, this is a mild sort of subluxation that you will be seeing maybe around 60 degrees or something of that kind. And this is a routine cataract surgery that we try to go ahead with this. But whenever we have cases like this, we have to be very careful, and you have to be ready with plan B if plan A actually does not work in your cases. So as it was said before, doing a capsulorhexis is quite difficult. Many a times you might have, a lot of picodonesis going on at that point of time. It might hinder you from doing a capsulorhexis. So then you also need to support your rhexis. Meanwhile, I have seen many of the surgeons, supporting the rhexis with the hooks or with the capsular bag. Again, it depends upon the capsular hooks depends upon the personal choice. So as you see in this case, phacoemulsification could be done, and the things, they progressed quite well. It did not seem that there was a major kind of phacodonesis during this. The capsular bag is good. So this case seems to be quite simple, and you can just go ahead and you can place up the capsular ring inside the capsular bag, so that works and helps in distension of the capsular bag at that point of time. And you have to be very careful when you slip this capsular tension ring inside, because once it goes inside the capsular bag and into the equatorial area, it's very difficult to get it back. So when it goes inside, it's always there. Secondly, I prefer to use a three-piece intraocular lens for one simple reason, that in case if I come up with any other subluxations or any other complications in future, I can convert this case directly into glued IOL procedure. I won't have to externalize or remove this intraocular lens. Now, in this case, there's also a defect in the iris. So the preferred surgery for me is the single pass 4-throw pupilloplasty procedure, which I have pioneered into this surgery. So this surgery, it actually works very beautifully. You have to take just 4 throws and you are just done with the procedure. It's just a single pass, so that is how it derives its name. And there is minimal intraocular manipulation with this single pass 4-throw pupilloplasty procedure. So this is a preferable method for me. Going on to a next case, if you have a case like this, I do not believe in putting Sione's ring and then fixing it up, because this is a massive kind of thing. And you would be stretching the capsular back to a maximum extent, if you try to fix it. This kind of, I've seen many of the surgeons, again, it's a personal choice. In the end, actually what happens is you are over distending the capsular bag when you have such a massive kind of thing. So these is a capsular, in these cases, I prefer to do lensectomy with vitrectomy and then go ahead and do a glued IOL secondary IOL fixation. So actually what happens, in these cases is that whenever you are doing a glued IOL procedure, you should be having a fluid infusion inside the eye, and that's very important. First thing is that do not do a secondary IOL fixation without fluid infusion, because you do not want the eye to collapse during the procedure. Secondly, when you are doing a lensectomy, you have to be very careful that when you are trying to cut it off with the vitrectomy probe, you do not encapsulate the iris tissue inside the vitrectomy cutter, because that can happen at any point of time, because you're working at a very high cutting rate, and also with the moderate amount of vacuum that is going on at this point of time. Although you keep on flipping in between the vitrectomy cutter and the vacuum, but still you have to be very careful with it. Secondly, when you have very big eyes and where you must have seen that I have created a peripheral iridectomy. We try to do this because, when you enter inside, you do not want to, when you do a sclerotomy, you do not want to drag the peripheral iris tissue. So this is how the 3-piece foldable intraocular lens is being now loaded. And when this sclerotomy, when the gluteal forceps or the end-opening forceps goes inside from the sclerotomy side, at that point, we try to create a peripheral iridectomy so that there is no dragging of the iris tissue. Because what happens, when you have a big eye, you're trying to come anterior and you're trying to do this. So you might pull off the peripheral iris tissue. So in order to prevent that, peripheral iridectomy is done. This is a very clinical important point which should be taken into consideration. What I want you all to appreciate is, although the haptics are being externalized, but the fluid infusion is continuously on. So this is very important, which I see missing in many of the surgeons doing secondary IOL fixation procedures. They try to do it without a fluid infusion. I think fluid infusion is a must. That really makes your surgery quite easy, and even the postoperative outcomes are really good because, there is a minimal manipulation that is going on when you have a fluid. It has to go. You cannot work in a collapsed eye. So having done that, having the fixated and having put these into the scleral pockets, you are all set and you're all done for this case. Although it's not so simple as it looks in the video, it has its own challenges, but that is what I think comes with the experience of a surgeon. So fluid infusion, you can use anterior chamber maintainer also. It's not necessary to use a trocar infusion. You can use that, and you can do it when you are putting up the glue. You need to dry up the entire surface area. There should be no fluid coming, otherwise it washes off whatever amount of glue that you are putting into it. I would like to show you one more thing is that, when you might be having a cases like this, microspherophakia and a wandering lens moving around everywhere. So in these cases, lensectomy with vitrectomy is done. I'll try to show one of the methods that we have tried doing it recently is that, it's a handshake riveting flange technique, which I published in the Journal of Cataract and Refractive Surgery. So I'm trying to show you this in cases of aphakia, in case if you want to do that. Yeah, let me mute this. What you need for this surgery is you need a 26 gauge needle and you need a 3-piece PMM intraocular lens. What is actually done in this surgery is what you see in this animation. The initial steps are similar like what you do in a Yemeni. 2 mm by 2 mm markings, and you take the needle, 26 gauge needle, and it goes inside. You take a 3-piece foldable. The problem in our country is that we do not get haptics, PVDF haptics. We do not have those lenses here. So we have to do with whatever we have into our practice. So what you see here is that, after externalization and after the flange that has been created, what has been described by Yemeni, the flange was pressed. So that is what we call it as a riveting. We try to do this riveting. Why? Because, we have used a 26 gauge needle. Actually, even the thin gauge needle is also not very commonly available. So you can do this method, use a 26 gauge. When you create a rivet, there is no way that your haptic is going to slip back because the intrasteral tract which is created with a 26 gauge needle is comparatively larger than what is created with a 30 gauge needle. So when you're using a 30 gauge, you can just create a flange, but when you're using a 26 gauge, you want to prevent the slippage back inside. So it is always better to create a rivet. So that works very beautifully. Otherwise, most of the steps are quite similar to what we do in a Yemeni method. The second advantage with the handshake riveting is that when you have externalized the leading haptic and when you have created this rivet, what actually happens is that you can again push back the leading haptic inside. So, your trailing haptic takes the original position. So you won't have any issues with externalization of the trailing haptic. So that is another advantage that goes on with this procedure. So this procedure, it actually works very beautifully. You see here how the rivet is being created and then it is pushed back inside. I'll just run it because I think we're running short of time. So once this goes back, you can just manipulate the trailing haptic and it becomes very easy to flex this. Otherwise, this is the surgical step where most of the surgeons, they keep on struggling. You can do a handshake technique and then you can just go ahead with that. You need not bother about the leading haptic. It is not going anywhere. Otherwise, what happens is that if you do a double needle method in this, you will also be having the other previous needle inside the eye. So this is one of the methods that really works very well. I'll just forward this a little bit. This is the OCT, which shows that. This is another video, but I think I need to stop this here. This shows the similar method. So thank you so much. I think I could not cover much more in this, but anyway, thank you so much.